Good evening, everyone. Good evening. Welcome to our speaker series tonight. I'm so glad you're joining. We are thrilled to have an expert speaker leading our Heart Health Month discussion this evening. So I am glad you're with us. So I'll give everyone another minute to pop on as we're letting our guests tune in, but we're going to have great attendance tonight. And while our guests are joining, I want to take a few moments and introduce myself. So my name is Erin Pellegrin. I am our Senior Director of Culinary Nutrition and Education. If you have joined our education events before, I'm usually here with our founder, Sue, leading these monthly segments. And we're in for a treat tonight, a lot of learning and a real professional in the cardio-oncology space. And we're thrilled to have her in our local Philadelphia area. So we'll give another few minutes. If you are new to our education segments, we are recording, and tonight's speaker series will be available in our Unite for Her library in about a day or so. So you can be sure to come back, re-listen, share with others that may benefit from this discussion. So as with all of our segments, they'll be coming to you in our video library. So of course, before we move forward, I want to take a moment and pause because we could not continue to bring education events like tonight without the support of our sponsors. So tonight's speaker series is presented through UFH Connect by West, Merck, Lilly, Novartis, and Gilead Sciences, with support from gold sponsors Pfizer, GSK, and Daiichi Sankyo. And we have additional support from Tercera Therapeutics and Veristem Oncology. And we are so grateful for their ongoing support of our entire education platform. So tonight, I will ask that everyone keep themselves on mute. We will move through the presentation first with plenty of time for questions at the end. And again, we will be recording and will be available on our video library. I will put that link in the chat so you can come back and watch. A few reminders for what we have to look forward to for the rest of February. We've got a lot of great things coming your way, starting with tomorrow. So we are hosting a special Valentine's Day meditation focused on joyous love with none other than Michelle Stewartz, our amazing yoga advisor. And that will be live on Zoom. We'll be streaming that to our Facebook page as well at 12 noon Eastern time. So if you want to register and join Michelle on Zoom, I'll have that link in the chat for you. But you can always visit uniteforher.org/UFH Connect to register. In addition, we have our virtual hangout coming later this month. So that is on February 25th at 5 p.m. Eastern time. You can join us on Zoom. And we are talking all about gentle skincare with our friends at Acure. So they have been a longtime partner of Unite for Her, and we will be joined by one of their expert staff talking about what we want to be mindful of and the skin changes that come along with cancer treatment. And as you're using products or we're moving through the seasons, what we want to be aware of. So it'll be a really great engaged virtual hangout. That's February 25th at 5 p.m. followed by our Ask the Experts the next day. Our Ask the Experts is streamed to our Unite for Her page. So that is taking place on February 26th at 1 p.m. Eastern time. And I have the pleasure of being joined by Cal Cates, the CEO and founder of Heal Well. And we will be talking about understanding the spectrum of grief and loss in metastatic breast cancer. So we know that this can be a challenging and emotional topic, and I feel honored to have this discussion with Cal, who we know leads these talks with grace and openness and love and peace. So all of that, and of course you can submit your questions to us, but we will be walking through what that looks like, the spectrum of what that may feel like as a metastatic patient. So hopefully you will join us for any or all of our education segments that we have coming up in February. And again, you can visit uniteforher.org/UFH Connect to sign up and view all of our recordings. So feel free to say hello in the chat and put in where you're tuning in from. I know we'll have members from across the country. And while we are saying hello, I want to introduce our expert so we can jump right in tonight. So it is my pleasure to introduce Dr. Hamad. She is a distinguished cardiologist and leader in advanced heart care at Temple University Hospital in Philadelphia. Dr. Hamad serves as the Director of Advanced Heart Failure and Transplant Program, the Director of the Cardio-Oncology Program, and Medical Director of the Mechanical Circulatory Support Program, as well as Program Director of the Heart Failure and Transplant Fellowship. She's a professor of medicine at the Lewis Katz School of Medicine at Temple, and her expertise spans advanced heart failure therapies, mechanical circulatory support, transplantation, and that intersection of cardiovascular and cancer care. A dedicated clinician, educator, and innovator, Dr. Hamad's contributions have helped shape care for patients with complex cardiovascular conditions and foster that multidisciplinary collaboration in cardio-oncology. So please join me as I welcome our incredible expert tonight, Dr. Eman Hamad. How are you? Thank you so much for joining us tonight.
Good evening. Can you hear me?
Yes, I can.
Wonderful. It is really an honor to be here and to share what I know about cardio-oncology and answer some questions for all these wonderful women from all over the States. So it's great to be here.
Wonderful. Thank you so much. I will let you take it from here.
Thank you. Thank you. Okay, good evening, everyone. Let me share my slides. Let's see. Can you guys see my slides?
They look great.
Okay, perfect. Now, let me see if I can put you guys back on the screen. Okay, there you go. You disappeared, but you're back. Okay. So, I will be talking to you about cardio-oncology, and cardio-oncology specifically about cancer in the heart and what patients should know. So, what you all should know with a focus on breast cancer and ovarian cancer. And these are the key elements that I want to touch on. I want to tell you what cardio-oncology is, a little bit of background, and then the definitions of what does it mean to have toxicity from cancer agents. And we'll talk specifically about what these agents are and then what toxicities are linked to them. We'll talk about radiation, we'll talk about hormonal therapy, and then really the big focus is on prevention and monitoring, because I think that's kind of a big portion of this, what you need to know and what you need to do. So starting with cardio-oncology, and cardio-oncology is actually a subspecialty that's focused on preventing, diagnosing, and managing heart complications that might arise from treating the cancer, and at the same time managing those risk factors that you might come with before you have cancer and cardiac things that you might have after you're done with cancer. So we want to be part of every single phase. And really, the goal is to team with oncologists in order to be able to maintain whatever treatment you need to take care of the cancer, and at the same time watch your heart so your heart is not harmed. So it's a team approach. So, I work very closely with the oncologists in order to help prevent damage to the heart and be sure that we're able to get you through that journey of cancer, and at the same time protect the heart. So that's what the specialty is about. And we're going to dig in a little bit deeper. So this is just a map of the United States. And basically what it shows, it's that there's an overlap between cancer and heart disease. So here you could see in these brown areas here, this is the rate of heart disease. And this is where we have high rates of heart disease with the dark colors. And then this is where cancer is. And you can see here in the dark areas also that cancer is highest in these areas. So we could see that even geographically, cancer and heart disease overlap. And there's many reasons for that. And we're going to get to that. Also here, we see that, by far, cancer and heart disease are the most common disease conditions in the world. And we see it overlaps even when we look at lifetime risk of developing coronary disease at age 40 and lifetime risk of developing cancer. It also overlaps for women and men alike. So there is attached risk factors that really are same risk factors that are present for heart disease that are present for cancer. And we see here the overlap with risk factors and overlap geographically. So we know that they are connected. And we know, thankfully, that cancer therapy is more effective than ever before in treating cancer, which is amazing, right? So the 5-year survival just for breast cancer, for example, was 76% in 1975 and now 93% in 2017. And the latest data even reflecting even better and better improvements. And we could see here just from the SEER registry, looking at breast cancer survival for different stages. So we've come a long way in treating cancer in general. And, focusing specifically on breast cancer, we've come a long way, which is really great. And a lot of this is because we have advanced screening, advanced targeted therapies, personalized oncological treatments, and at the same time, the improvement in survival rates means that we have more survival from cancer, but we still have that risk of cardiovascular disease. And here, this is data also from the SEER registry that shows us that in any patient, heart disease in the red and cancer are likely to overlap, but then cancer kind of takes a dive and the rates of cancer and death from cancer goes down, but heart disease persists. So even after we're done with treating cancer, that heart disease persists and the rates continue to go up. And this is data looking at even in early stage breast cancer, cardiac disease has an impact. And what this is showing us is looking at breast cancer deaths, age less than 50, age more than 50, and then other deaths, so other reasons. And we see here that the other causes of death go up and they're the highest. And half of these other causes of death are cardiac reasons. So even though patients have cancer, most likely 50% are really dying from heart disease. And it remains true that the number one killer of women and men, but the number one killer of women is heart disease. And more people die from heart disease more than all forms of cancer combined. And that's why, as we are treating cancer, we want to watch the heart closely to make sure that you don't treat your cancer and then end up with heart disease. And that's why the field of cardio-oncology exists. So let's define some of these toxicities. What do we mean when we say toxicity? Toxicities are classified based on the time that they happen. And a lot of these studies come from childhood cancer survivors because we've been able to watch them the longest. And that's where some of these guidelines come from. But when we say acute, we say this happened after one dose of treatment. Early onset or chronic, it can be within that first year of getting treatment. And the majority of breast cancer treatments and ovarian cancer, they're within this arena, that 1 year mark. Late onset chronic cancer development of cardiotoxicities can be years after. And we'll talk about what agent can cause side effects years after and needs to be monitored closely. Now, there's a lot of risk factors that we look for even before patients start treatment with cancer therapies that might be harmful to the heart, because we know that there are patient-related risk factors that can make the risk higher, and there are treatment-related risk factors. So things are related to risk factors that you already have coming into your treatment, and risk factors that have to do with what agents you're being treated for based on the cancer. And some of the related risk factors that you have before are high blood pressure, diabetes, cholesterol. These are things that we ask about because we want to make sure that they're optimized. If you have heart disease from prior, like maybe heart attack or a heart failure, or maybe a stroke in the past. And also age. So those who are at a young age or older age are at higher risk for developing these toxicities. A lot of people have had cancer when they were young and they had radiation. We call it medicinal radiation because at the time they didn't have protection to protect the heart. So they come into their treatment for breast cancer already having risk factors. And then, of course, smoking and alcohol, and then some genetic variables that, people can bring to their cancer before, which can be genetic. There could be familiar predisposition. And some of the treatment-related risk factors are how often are the doses being given? And is the dose being given in a bolus where it's just all at once, or is it a continuous infusion? Also, the total dose. So for things like anthracycline, which is something that is used a lot in treatment of breast cancer, it depends on how much the total dose is that somebody gets that decides how toxic it is. And then, of course, when you get treated for cancer, sometimes, it's not just one agent. So you get chemo, then you get something like a targeted agent like Herceptin, then you get radiation. So it's what else are you getting that might make your risk higher? And then sometimes when you are getting doxorubicin, which is one of the agents that is used in breast cancer, is the agent an agent that can be absorbed better or less toxic to the system. And now, and I just put this just to kind of showcase, now we have better definitions of how do we diagnose the toxicity. So now we have professional societies. So in the past 5 to 10 years, there has been a great advancement in the field where now we have specific guidelines. We have a rule book that tells us how do we define toxicity? How do we know if a patient is developing it? And that's why we all are on the same page and use a specific definition, where in the older days, we all kind of had our own definition of toxicity. And this is really helpful because now we have one definition of what toxicities are to the heart. Now we could do more accurate research on patients and figure out what's the best approach, because at least now we have one unified definition in all these societies that have come up with these guidelines that are very helpful for us. We also, based on these guidelines now, risk stratify patients. So now we look at things before we start treatment, which is kind of some of the things that I discussed in the prior list. Age, genetics, what's contributing to you having risk of toxicity. We look at prior risks of cardiac abnormalities, like you have a heart attack in the past, you have heart failure in the past, you were exposed maybe in the past to treatment for cancer in childhood. So all that, in addition to some of the basic testing that we get, we get echocardiograms and ultrasound of the heart, we get some blood work, we get, physical exam, and all that together, we put together to say, this is your risk going into cancer treatment. You're either high risk, low risk, moderate risk, and that decides how often and how frequent we want to follow you through this. Now, talking about some of the agents that cause cardiotoxicity. So there's a lot of agents, and I have on this slide some of the main agents, and we're going to dive deeper into the specific ones that are for breast cancer and ovarian cancer, but some of the main things that are affected. So we have some agents. These are agents that are called vascular endothelial factor inhibitors, which you don't need to know the name, but bevacizumab, which is a VEGF inhibitor, is actually part of the treatment regimen for ovarian cancer. And that can cause high blood pressure. That's one of the notorious ones that causes high blood pressure. It could also contribute to more risk of having coronary disease. And this is an artery. And here we just see that, it's starting to develop a blockage. And then also this agent can also cause blockages in the venous system as well, so clots. And then other agents, like the agents that we use to treat breast cancer, like HER2 targeted, trastuzumab, pertuzumab, are some of the agents that you might have heard of already. They can cause damage to the heart muscle. Other agents that are used to treat breast cancer are anthracyclines, like doxorubicin, which you might have heard about too, can cause weakness of the heart muscle, heart failure. Other agents like cyclophosphamide, that's also used in the treatment of breast cancer, also can cause weakness to the muscle of the heart. And there are other agents, that contribute that are really not part of the treatment of breast cancer or ovarian cancer, but basically in general, they cause the same thing. They affect the cardiovascular system by causing blockages in the heart or causing blood pressure issues or causing heart failure. Now, radiation is a big one because radiation affects multiple areas. Radiation can increase the risk of developing coronary disease. Can also harm the valves inside the heart. It can also cause damage to the lining of the heart. And also it can cause bad rhythms in the heart. And it can also cause heart failure with time. And then, we're going to talk specifically about radiation when we get to that, but it can affect a lot of areas in the heart. Now, that's a general picture of where the agents work. Now, in our world of cardio-oncology, we have definitions that we use, and we call the agents either non-reversible damage, so they cause damage that might not be reversible, and some of them have reversible damage, which we think usually is reversible with medications or stopping the agent. And we're going to mention that when we talk about the specifics. So we're going to dig in a little bit into the field of breast cancer treatments. Um, a lot of breast cancer treatments, depending on what receptor positive or receptor negative or hormone therapy, the regimen might change. But this is kind of in general what it looks like. So doxorubicin is a form of anthracycline. It's a chemotherapy agent that many breast cancer patients can have. And this really causes a toxicity that causes heart failure. And we'll go into that. We're going to go into each one of these agents a little bit. Targeted therapies for those who have the receptor, the HER2 receptor. That's what this is, trastuzumab, pertuzumab. Immune therapy, this is the new kid on the block. So some patients do get immune therapy, and mainly it's Keytruda is the drug that you might hear about that some patients have. And then we're going to go into endocrine therapy and radiation. And ovarian cancer has some similar agents. So we have agents that are called platinum agents. So carboplatin, paclitaxel are some of the agents. We have agents that are called angiogenic therapy. So you might heard of bevacizumab. That's one of them. And then the PARP inhibitors is another one, olaparib, which you might hear about, that can cause also some side effects. Immune therapy, again, is one of the agents that some patients can be on, also Keytruda. And then we're going to talk about the endocrine therapy or the hormone therapy. Starting with doxorubicin. So doxorubicin or anthracycline is one of the older agents that we know about in the treatment of breast cancer that causes heart failure. It harms the heart muscle. This is the one that we think might be non-reversible, even though in the later stages, now that we have more data, we have seen patients who do have reversed this toxicity. The risk and chances of getting doxorubicin toxicity is only 9%, 9 to 10%, so it's not a lot. But we know, and this figure just shows us from childhood survivors of cancer, that the total dose where we see problems start happening is around this 450 dose. And currently, usually patients get up to 240. So they don't really get up to here. So now we know where the dose is that we have to kind of, draw the line of where the toxicity starts. So we have more information. We know the target dose that we need to stay below. And we know some of the risk factors, like we mentioned before, age, female gender, a history of cardiac problems. And that's why we look for all this even before the treatment started, so we can better risk assess patients. And this is just a quick slide that just shows us this is a muscle cell. And doxorubicin is thought to break down these muscle cells and cause gaps in between them. And that's how it weakens the muscle. With that said, we know from our studies now that with patients who do have anthracycline or were treated with doxorubicin, if we find this early and we put them on the medications that we know help the heart, we notice that they have a chance of improvement and their heart function improves. And that's why now our guidelines tell us that we need to check their heart function with an echo or an ultrasound before they start treatment and continue to follow them throughout. We also know from our data and from trials that usually this is when patients start having these toxicities. And we see this marker here. This is basically tells us the 1 year mark. So 1 year is when we see it kind of level off. There's no more. It's usually in that 1 year window is when we see the most of it. But it does happen that sometimes people can get it. But it's comforting to know that really close monitoring, at least in that first year, will catch a big percent of these patients who might have a toxicity. And that's why we frequently repeat the echocardiograms. And also, this data shows us that, we talk about it a lot about the cardiotoxicity because that's all we see. But really, it's just 9%. So 9% is not a big number. And we know that 98% of the cases happen within that first year. So it just gives us an idea of that first year is important to monitor patients closely and that the percent of patients that do develop toxicity is very low. Nonetheless, we need to follow them. The next agent in the field of breast cancer is what we call HER2 targeted therapy. And these are for patients who have HER2 positive, and that's the trastuzumab and the pertuzumab that we mentioned before. And we think that this agent has reversible toxicity, which is really a good thing. So we know that with patients, we put them on the medications that help their heart improve, and we could start them back on their Herceptin because we know it's beneficial. Usually patients are on it for 1 year, and some patients are on it for longer, depending on what stage their cancer is in. Um, and this is just a quick figure that shows us. So Herceptin, the heart has a natural or HER2 pathway that protects the heart. And Herceptin, the medicine that we use to treat cancer, actually blocks this protective pathway. And that's one of the reasons that Herceptin can be toxic because it blocks this protective pathway. And because of that, this just shows us that in the past, they used to give anthracycline, which is doxorubicin, at the same time as Herceptin, which would actually cause a big range of toxicity. This is the numbers of people who develop toxicity from it. And because of that, they learned that if they wait 30 days, 60 days, 90 days, if they wait, we'll have less people affected. And that's why now, they're not usually given at the same time because of this data, because we know that two toxins together will cause big damage. So we're learning from the experience of these clinical trials. We also know from Herceptin as well, this is just a study that looked at patients who did drop their heart function. Once we start the medications for them, just like we did with the doxorubicin, their heart function does improve. And that's why we monitor patients who are on Herceptin. Every 3 months, they have to get an echocardiogram to monitor their heart function because we want to catch things early so we could get them on these medicines that help. We also know from our data that being on a statin or a cholesterol medicine is protective, both for patients who are on doxorubicin and Herceptin. So that's why we check cholesterol in everybody. We want to know what the risk factors are. And we also know from our studies that even though patients do develop cardiac dysfunction, we have now guidelines that help us manage them closely, put them on these heart meds that are helpful for their heart, but at the same time, we could continue treating them with the treatment that's going to help their cancer. And that's both for anthracyclines, doxorubicin, and for the Herceptins. And these guidelines always are updated regularly. These guidelines are from 2022. So updated guidelines. We also have guidelines that just came out last year. So guidelines are continuously being updated so we know what we're doing and they're based on trials and expert consensus. So with doxorubicin and Herceptin and kind of the key takeaways for breast cancer is that monitoring for the toxicity is critical. Knowing what the risk factors are is critical. And getting the echocardiograms regularly is critical so we can put you on the medications that can help improve the heart function if it was to drop, and at the same time, continue treatment of the cancer. This is another agent that I mentioned. It's immune therapy. You might have heard of that. We talked about that when we mentioned Keytruda. Keytruda can cause inflammation of the heart. We call that myocarditis, but it's only 1%. It's very low. Of course, we're just talking about the heart, but it can cause some other inflammation in the thyroid and lungs and other places. But as far as the heart is concerned, it can cause some inflammation. And that's why when patients are on it, we like to monitor that as well in order to detect it. And we usually start patients on steroids in order for that inflammation to get better. The key here is that we don't want to just stop the agent if patients do develop the toxicity. We want to treat them and give them the ability to continue medications that are necessary to treat the cancer. Because remember, that's our goal. Our goal is to treat the cancer and protect the heart at the same time. Other agents that we mentioned, and this is mostly for ovarian, bevacizumab is an agent that's used, and usually it can cause high blood pressure. 77% of patients on this agent develop high blood pressure. So usually we monitor and we treat the blood pressure aggressively, and it's because it changes how the arteries look. And that causes the increased blood pressure. It can affect the kidneys, affect the arteries in the heart. So that's why we want to make sure that we monitor closely and control that blood pressure. Radiation is another one, and radiation is dose dependent. So the higher the dose of radiation and the longer the time, the more the side effect. And this just shows us over time. So this is 5 years from radiation is when we start seeing things. And that's why our guidelines are based on that. 10 years, we see more and more side effects, but it depends on how much the dose is. And that's why when we look at our guidelines tell us to look at how much dose. So the higher the dose that you got, the more frequent we're going to watch you. And of course, if you had something like doxorubicin or anthracycline at the same time, we're going to watch you even closer. And this just looks at some of the other things that we talked about as far as where does the radiation affect. It can cause problems in the lining of the heart. It can cause increased atherosclerosis, which is coronary disease or blockages in the heart. And of course, can affect the muscle and the valves of the heart. This also looks at, radiation based on the dose. So patients who have higher doses, this is the higher doses, are more likely to have effect of the radiation. And this looks at patients who have prior cardiac issues. So they have risk factors. And those who have risk factors and have the radiation are also most likely to develop side effects of the radiation. And just to touch on hormone therapy. So we mentioned that, hormone therapy is present both for breast cancer and for ovarian cancer. But basically, the main thing with hormones is that it can increase those risk factors that we mentioned. It can cause higher cholesterol, higher blood pressure. So, and if you notice, the common theme here is those risk factors. Before therapy, monitoring the risk factors. During therapy, monitoring the risk factors. After therapy, controlling those risk factors is critical. And also, some of them, like the ovarian suppression agents, like leuprolide, can also cause an increase in lipids and thrombosis, which means clot formation, which can be a problem for the heart and also can cause vein thrombosis, like in the lungs or in the legs. So these are some of the side effects of the hormones. Now, and just to touch about, hormone replacement therapy. So hormone replacement therapy is something that, we've heard about recently a lot because it's been in the news. And this is like for postmenopausal women, perimenopausal women, and not just for patients who have, surgical menopause because of oophorectomies. But the studies that were done on hormone replacement therapy in the past came out and said that there was cardiovascular side effects. And that's why they put a black box warning on them, the FDA. But then, looking at those studies, they were done a different formulation, different kind of hormones, and it was done in women all age 60 and above, but not in that perimenopausal, 51, as soon as menopause hits. It was really done later. So now the FDA had removed the black box warning because of that. So, for women who have decreased hormone levels, whether because it was surgical menopause or, menopausal, should address this with their GYNs and their cardiologists to see if they are candidates for this. Now, I think the focus here is really on long-term prevention, monitoring, and follow-up. And the key here is, we know that, cancer patients, because of the cancer and the inflammation that goes with it, have really decreased reserve. So, and because of that, we need to look at everything. So we need to look at all the other medical problems, from anemia to lung problems to muscle dysfunction, weakness. And then also they have problems with lifestyle factors like physical inactivity, weight gain. All those things are things that we can work on in order to help increase cardiovascular reserve, because those all play a role in cardiovascular reserve. And our goal is really to look at, like we talked about, baseline risk factors, optimize them, look at treatment related factors, and try and improve those and monitor those, the toxicities, and look at some things that are indirect. So, poor nutrition, deconditioning, you're not taking your meds the way you're supposed to, and psychosocial factors, which we all know play a huge role in this. So optimizing and doing prevention to improve cardiovascular risk factors is critical. And, we're going to go into kind of some details and really kind of focusing on the AHA recommendations that we're going to go through in detail. But this is from the ASCO clinical practice guidelines that tell us for survivors of cancer, really monitoring pre and looking at the risk factors that we will review and doing our ABCDs, which is awareness, aspirin if they're candidates, blood pressure, cholesterol, smoking, diet and diabetes, exercise, and then following them through their cancer treatment to make sure these risk factors are optimized and monitor their EKGs, their echoes, etc., based on what agent they are on to see if they develop toxicities, and then following them afterwards so we don't miss a toxicity if it was to occur afterwards. And then there's a big emphasis on exercise. There are so many studies that came out now that show that exercise actually improves cardiovascular health and reduces the risk of developing cardiovascular side effects post. And that's why exercise is important and is recommended to improve functionality and improve reserve post treatment. And the American Heart Association really, recommends the Life Essential Eight, which are really great for us to learn and focus on. So the Life Essential Eight focuses on the connection between mind, heart, and body, and things that we should all do really, irrespective of cancer, but also preventative. We should know what our numbers are. There are four key health factors. Blood pressure. The target blood pressure is less than 120, less than 80. Those are the new recommendations. So 120 over 80 is a borderline blood pressure and it should be less. That's the newest guidelines, because the more and more research we do on blood pressure, we find that the lower, the better. Cholesterol, knowing your numbers, knowing what your LDL is, what your total cholesterol is. The HDL is a good cholesterol. So having a high good cholesterol is good. And that's exercise, antioxidants. What's a healthy weight for you? What's your BMI? A lot of people don't know what their BMI is. They don't know what their blood pressure is. They don't know what their cholesterol is. And then blood sugar is another thing. What is your blood sugar? What's your A1C? The A1C tells us how controlled is your sugar over the past 3 months or so. So it gives us a number to kind of go by. So you should know what your A1C is. Some people are just pre-diabetic, and there's a lot of ways to fix it, from working on your weight to working on your diet. So these are four health factors that everybody should know. And I always say that, we all need to be our own hero, right? You need to seek care because early detection and prevention is critical. And then there are four key health behaviors that we all need to do as well. So, of course, smoking is a big one, but adequate sleeping. This was recently added in the latest update. It was the seven essential, and now it became the eight because everybody realized, and data shows us that a good amount of sleep helps the body regenerate. And this is even more important when you do have a disease, whether it's cardiovascular disease, cancer, etc. The body needs that time to rest and regenerate. And of course, diet is a big one. Eating a healthy diet is critical. Physical activity, even before cancer, is critical. And the recommendation is 150 minutes or more of moderate intensity aerobic activity. And this is something that you don't really have to go to the gym for, whether you do it in your house, whether, you take a walk around the block, whether you put something on a video and you do it at home, or in between work hours, you go around and walk around the building and come back. So there's many ways to get that physical activity in that doesn't require you to go to the gym. And just getting some movement is critical, just getting that heart rate up. And then another one that, I add as far as behaviors, I always say that learning CPR is critical. And I actually added my own little thing that I think one of the behaviors that we should all have is learning CPR. Being able to rescue a life and help someone is critical. And also knowing where your AED is. Wherever you are, work or school, or know where the next AED is. So this way, if somebody does fall, you know how to help. And then this is really this is our criteria, our guidelines of how do we know how to watch, people with different kinds of cancers. And we start with the risk assessment that we had in the beginning. What was their risk? So were they low risk patients? A low risk patient means they don't have coronary disease. They didn't have a history of anything. Blood pressure is controlled. They don't have blood pressure. They don't have cholesterol. They don't have risk factors. Maybe they're being treated with one agent like Herceptin. They're still low risk because they don't have a lot of risk factors. So basically, during treatment, and that's what we want to do. We want to have a plan for every single stage. So during treatment, we want to monitor them. So we have a guideline, for monitoring them for standard surveillance. And then, of course, we talked about that 1 year after therapy, and we said that the majority of folks who are going to develop anything, it's usually within that 1 year. So following them in the 1 year. And then annual assessment. And when we say annual assessment, it means an exam, a physical exam. Seeing how you're feeling. Are you having any symptoms? Is anything different? Are you having shortness of breath down? Now, is your blood pressure high? Is your cholesterol high? So having an assessment. So this is for the low risk folks. And of course, it depends on what agents you had. I would say for these patients, if they had doxorubicin, I would definitely get an echocardiogram, just to see, where they're at, and especially if they had a drop at some point. For moderate risk patients, so these are patients who did have a toxicity. These are patients who had maybe a drop in their heart function, or maybe they had elevated blood pressure because of the cancer. So these are folks who are kind of in the moderate range. And these are patients who should be evaluated more regularly. And then maybe those are the patients that we get the echocardiogram every 5 years. If they had radiation, we talked about the dose of radiation before. So if you have a high dose of radiation and at the same time you had doxorubicin therapy, then those are folks who I would evaluate annually, listen to them, make sure they don't have any valvular abnormalities that I could hear, EKG, lab work, and then get an echocardiogram. And at 5 years, unless they had symptoms before, I would get a stress test to make sure that we're not missing them starting to develop some of those coronary problems that we talked about with long-term radiation. And as I said, the majority, kind of 10 years is where we start seeing it. But some people, depending on their risk factors and the dose of radiation and where the radiation was, might develop it earlier. And then we have the high risk group. And the high risk group are those individuals who maybe came into it with having cardiac disease, having high blood pressure, having cholesterol, having diabetes. So they're already at high risk. And you could see that, with this patient population, these two groups should be referred to a cardio-oncology or a cardiologist. Even during the treatment, even before they start developing things, because they're already at a higher risk and should be monitored. And then the first year after we said is critical. So you definitely want to, do an echocardiogram, assess them, follow them very closely. And these are the patients that I might get an echo actually every year on them and monitor for symptoms closer because I'm expecting them to develop some of the side effects sooner, especially if they had radiation or doxorubicin. And as we mentioned, Herceptin and all the other agents are the reversible agents. So I don't expect somebody to, have a side effect of Herceptin 5 years or 6 years after. Doxorubicin is the one that we do worry about coming years and years and years after, and radiation, of course. Herceptin is not one of those, and none of the other agents as well. So basically, knowing that you have to have regular follow-ups and knowing to monitor your symptoms is critical. And also, something to point out, I was just, because it's Heart Month, I was just giving a talk today on, heart disease in women versus men. And that, symptoms with women as far as, heart attacks and heart disease are different than men. And for a long time, really, women were underdiagnosed, undertreated because they present differently. And all the research and all the study was on men. And then now we have a lot of groups and a lot of research and Go Red for Women and a lot of movements helping to bring women more to the light in order for them to be treated and included in clinical trials. But with women, you might have, jaw pain, arm pain, you just feel not normal, nausea, vomiting, that's not common, but it might not be that typical an elephant sitting on the chest pain. So, be aware of your body, and, seek care if you feel any of these symptoms. And really none of the cancer agents that we discussed today can cause like an acute heart attack per se. But it's really the long time side effects of them later down the road with the radiation and everything else, and risk factors. So these are symptoms in general to be aware of. And these are some of the resources that I thought are very helpful from a patient perspective. The International Cardio-Oncology Society has a lot of patient-oriented information that is patient-friendly, and they have some videos as well that are helpful. American Cancer Society as well has a lot of information on that, and they have nice videos and a lot of good data. ASCO, they have also a patient resource, a website that's really good. And then the NCCN has guidelines for patients which are also helpful, and the language and the way they're presented is easy to read. So I would recommend these for those who want to dig more in or ask more questions or look up any of these items that I discussed. And I think we talked about a lot of things. I'm sure you guys have a lot of questions. So we can Erin, open it up for questions.
Absolutely. That was wonderful. And yes, I think we all are in agreement that it was a lot of information, but the key takeaways were great. And I will say, come back and re-listen and redigest all of the information. But I do think you gave us some really great tips to take away. We had some really great questions in the chat. I wanted to start with one that several of our attendees chimed in on, and that being finding out the level or the doses of radiation they had, particularly if their radiation was 5, 10, 15 years ago, and they have no idea how much they got. How do they find that?
So, I mean, definitely you have regular follow-up with oncology, I'm sure. And that's in every single note. I think even if you have access to my chart, which most institutions now have a my chart, you could look at your own notes. But I would just ask my oncologist, by the way, what was the total radiation dose that I received? And they'll usually have that. And some folks had childhood cancer and then had breast cancer. So it's the combined dose. And also, I would ask how much doxorubicin for those who had doxorubicin, because some people had 2 runs of doxorubicin, rarely, but usually it's one. It's a 240 that they give. It's like the 4 doses, but some people have more. So know that, and if nobody ever told you that your agents are cardiotoxic, ask what was I treated with?
Yeah, wonderful. Thank you for that. Um, we had another question about finding a cardio-oncologist. So I guess this presents the question also, particularly if someone is at the start of their oncology treatment, is heart health something that they should bring up from the beginning in terms of, do they need to see a cardio-oncologist? Is there someone, when should that discussion be had?
Yeah. So I think if you're diagnosed with cancer, that's a discussion that you could have with your oncologist. So your cancer doctor can refer you to a cardio-oncologist and also cardiologists. So they know the agents. And they can, if they're, some of the agents are more complicated than others, so they can also reach out and refer you to a cardio-oncologist. But most cancer centers, I would say, have a connection with a cardio-oncologist. So when you do go, the first question to ask, especially if you know that you have risk factors, you have cholesterol, you have diabetes, you have a family history of heart attacks. So if you know that you're going into it with risk factors, then I would ask, are these agents toxic to the heart? The answer is yes. So what are we doing to find out, what my risk is? Technically, they should be getting an EKG and an ultrasound of the heart if the agent is toxic. And if you have risk factors, they should be controlled going into it. And that's something that really, even before cancer, you should be doing now. You should know what your risk factors are and make sure that they're controlled. And if they're not controlled, then work on it. I have a lot of patients who I just don't want to take medicine. But if your medicine is going to decrease your chance of getting a stroke, a heart attack, heart failure, then isn't it worth it to take the medicine? And I think, that's something that a lot of people struggle with. They don't want the medicine, but there's a reason for it, because we don't want you to develop what comes next if you don't take the medicine.
Right, exactly. Okay. And Ada had a great comment. Yeah, cancer centers sometimes have a cardio-oncologist. And right, just speaking, that may be part of the team, part of who they recommend. Absolutely.
And I'm sorry, just to comment on that, ICOS, which is International Society of Cardio-Oncology, has a
Yeah,
list. So if you go
yeah.
in, it has a patient portal, and it actually has all the cardio-oncologists in the nation that are board certified by them listed there.
Yep. And I did put that link in the chat as well, answering one of those questions, but I'll put that in as well. I think that's a really great user-friendly tool to find a person in your area. We did have a comment about asking for an echo strain. Patients need to do an echo strain to pick up any abnormality. Can you comment on that, or perhaps explain what that means for those
Yes.
that may not know?
Yes. So, as I mentioned, we have guidelines now, which is really great, and we didn't have it before. So, an ultrasound of the heart tells you what your ejection fraction is, meaning how much blood is being ejected from the heart. The normal is 50 to 55% because the heart doesn't empty out fully. It doesn't go down to zero. 50, 55 is normal. Now, sometimes before that ejection fraction is affected, the small muscle cells in the heart start showing signs of damage that are not affecting the ejection fraction. So the strain is basically the level of strain in these muscles that can tell us that maybe there's damage starting even before the ejection fraction drops. So now in our guidelines, we ask to get the echocardiogram with what we call strain. Because even if the ultrasound tells us that the ejection fraction is normal, the strain might be abnormal. And it might be a sign for us that instead of getting the echo in 3 months, we're going to get it after one treatment. Or maybe we're going to say, you know what, they have risk factors. So we're going to put them on the heart meds to prevent any damage now. And we have guidelines to tell us how to manage that. But that's what strain is. It gives us information even before the heart function drops. That's a very good question.
Yeah, that's great. Thank you for that. We had another attendee that shared where she is with their ejection fraction, diagnosed with heart failure. And having mentioned that, Dr. Hamad, I guess my question to you is, having a person's heart function be affected in one way or another, is that something they'll always experience side effects with, notice if as their ejection fraction gets lower? Or is it something that, like this individual was saying, their ejection fraction is 29%. It was 45 in 2011. They have absolutely no symptoms of heart failure. So is that common, or are we, I guess my assumption would be if a person was diagnosed as heart failure, there would be symptoms that come along with it, but that may not necessarily be the case.
Yes, so the majority of patients, when it comes to Herceptin and sometimes anthracycline, the majority of my patients are asymptomatic. That's the reason we get the echocardiograms every 3 months because they don't have symptoms. And the majority of patients don't go down to 29%. Usually 40s is where they land. So they're not going to be symptomatic with that. And many patients are not symptomatic with that. Because we think that the neurohormonal or the etiology of the heart failure, because it's not a damage to the heart like an ischemic attack or other patients who have heart failure, they don't have the same symptoms unless their heart function really, really drops low. And we're saying, 15, 20%, where they have profound heart failure. And in some ways, it's a good thing because they don't have symptoms, which means they'll function okay. But at the same time, that's why we have to keep on getting the echocardiograms because they don't have symptoms. Usually, patients who got doxorubicin and Herceptin and maybe radiation, those are the ones that end up kind of having that low ejection fraction. I follow close to 1,000 patients, and I only have one or two patients that drop that low. The majority of patients go to the 40s and recover afterwards.
Okay. Thank you for that. And certainly, if anyone has any questions, you're welcome to put them in the chat. You're welcome to raise your hand. We've had a lot of great sharing and dialogue in our chat. Another question that I had, just speaking with the Unite for Her member that was on adriamycin
Yes.
2 decades ago. The person was telling me, we were talking about this segment coming up, and she said, I have never had an echo. I've never had my heart
Oh,
tested at all. Asymptomatic, like not having any issues, healthy, active, all the things, but it's never been brought to her attention. Is that something that she should ask her oncologist or primary care physician?
primary
Let's just get
care.
this checked out. Yeah.
100%, 100%. So, her risk factors need to be checked,
Yeah.
the regular, and she needs an ultrasound of the heart. Unfortunately, in the old days, like I was saying, we didn't have guidelines. And I have so many patients, the majority of the doxorubicin toxicity patients that ended up needing transplant are those folks from the old days. People never used to be screened before or after. But,
Yeah.
I would say in the last 5 to 10 years, we know better. So yes, definitely 100% because doxorubicin is one of the ones, unfortunately, that we don't know when it's going to happen. Herceptin, we know it's less of an evil, I would say. But doxorubicin, it can happen 1 year, 2 year, 3 year, 5, 10 years after, 15 years after. So they should
Wow.
have, echocardiogram, I would say every 3 to 5 years, and of course with symptoms.
Right. Got it. Thank you for that. Uh, we had a question in the chat regarding Ibrance. Some of our members, yes, this person has been on it for 10 years. I've certainly talked to lots of Unite for Her members that are on it for long periods of time. Are you familiar if there is any impact from the medication Ibrance?
There's no long-term impact on the heart. Um,
Okay.
really, doxorubicin is the main notorious one as far as heart function that has a long-term impact, and of course, radiation.
Got it. Wonderful. Can you comment, and even as you're counseling your patients regarding exercise, and perhaps the type of exercise? We talk a lot about weight-bearing exercise, strength regarding bone health. We might think aerobic exercise for heart health. How do you usually counsel your patients?
So, I mean, exactly what the AHA recommends. So, at least 150 minutes, you want to get of exercise and you want to do, some aerobic activity, but also low weight bearing because you want to strengthen those bones, like you mentioned. So, I think getting, a balance of those two is critical. In order to keep your bones healthy and also at the same time keep that cardio up. And it could be really anything. You could, soup cans or whatever it is, just kind of a little bit of resistance.
Amazing. Thank you. And we did do an education segment in the fall of last year with a physical therapist that was a cardiac specialist talking about exercise. So be sure to check out our education library about that. Um, okay, couple last questions. This is a great question. Radiation to the right side. The heart is on the left. Should anyone with right-sided have anything to worry about? Love that.
Yeah, I mean, so, we do say that, the left side is what we worry about, but you have vasculature everywhere, right? So we still worry about radiation is radiation. It is 100% more, more damaging when it's on the left, but still radiation is radiation. So I would say much less of effect, but it's still present.
Would you say the same for proton therapy?
Yeah, I think it's the same thing. Definitely less of an impact when it's on the right side, but still because you have arteries and everything else, so you're still at risk for developing some, vascular disease.
Okay. Wonderful. We've had a couple questions regarding hormone therapies, anastrozole, SERDs. Um, any comment on being on those medications relative to heart health, or could that potentially be related with the decline in estrogen?
Yeah, so I think for those really the most important thing is they can help develop metabolic syndrome. And when we say metabolic syndrome,
Mm.
we're talking about high cholesterol, we're talking about blood pressure, we're talking about risk of sugar, we're talking about weight gain. So and hypertension and cholesterol are really the main ones. Depending on which hormone it is, we worry about those. And then some of them can cause increased risk of clotting or thrombosis. But I think, monitoring the risk factors when you're on the hormones is critical. And usually once patients start on them, I repeat the cholesterol 3 months after, even if they had it done right before, just because I want to see what's the effect on you of this start of this new hormone, because a lot of times you'll see a spike. So we want to make sure that you're controlled if you are on a cholesterol medicine. And if you're not, we want to start it. So 3 months after starting hormone, check your cholesterol in addition to your regular annual checks of cholesterol.
Okay, wonderful. And then we'll wrap up with this last question: CDK4/6 inhibitor Kisqali. This person, they've been monitored, but they wonder if Kisqali raises risk of other heart issues. And would that risk? Love this question. Does the risk go away once they stop the medication? Are you familiar with that at all?
Yeah, I mean, it causes usually arrhythmias, not so much heart failure, usually arrhythmias, and usually the risk does go away when the medication is stopped, and not everybody develops these arrhythmias. But usually
Wonderful.
we monitor the EKG to see if we call it a QT segment, which tells us if people are at risk for increasing it, and we monitor the rate of arrhythmias.
Wonderful. Okay, great. We have a couple questions about radiation on the lungs, but I feel like that may not be. Do you have a comment on that? Just it's come up a few times.
I mean, radiation can affect the lungs because it can cause inflammation, can cause
Mhm.
fibrosis. So if there's higher doses of radiation, it depends on how much the dose is, but it can cause inflammation and fibrosis and cause long-term lung disease. And it can affect the lining of the lung, just can affect the lining of the heart.
Got it. Okay. Wow, great questions. Thank you so much for being here with us tonight. This was a ton of information. We are so grateful for you being here. So we will use this as a wrap up. Any final takeaways or any final notes as we are concluding tonight's segment, but sort of still, into Heart Health Month?
I think the main thing is number one, know your numbers, know your eight essentials from the AHA, and then never doubt seeking care and getting a second opinion. If you don't trust what you heard from your doctor, just get a second opinion. It's okay to do that.
Wonderful. And the links that Dr. Hamad shared in her presentation will be sure to include with the recording of this video as well. So you can follow along, do that research, find a cardio-oncologist. So that's wonderful. Thank you so much.
Thank you for having me.
You're welcome.
Thank you.
All right. Thank you. And I will stop share and I will pop back up. Let's see. There we go. Wonderful. Well, with that, I want to thank you all for joining this incredible discussion tonight. Thank you for being here, learning. It was a lot to digest, but you had great questions, great sharing. Please come back and rewatch this segment. Like I said, we will include all of the links that Dr. Hamad shared. So be sure to check them out. Again, I want to give one final thanks to our education sponsors this evening. Unite for Her, it's presented by Unite for Her Connect by West, Merck, Lilly, Novartis, and Gilead Sciences. We have additional support from our gold sponsors, Pfizer, GSK, and Daiichi Sankyo, and additional support from Tercera Therapeutics and Verastem Oncology. Please be sure to join us tomorrow for our Valentine's Day meditation focused on joyous love with Michelle Stortz. It will be a wonderful way to kick off the Valentine's and Galentine's weekend. Hopefully, I will see you for the rest of our education events this month. You can view them all, sign up at uniteforher.org/UFH Connect. So with that, we will conclude our speaker series. Thank you so much for joining us, and we will see you next time. Have a great night, everyone.